is here also.
Are we still connected?
Yes, we are connected. I am just trying to square with the court reporter. I do not want to have a similar incident, and as soon as I square that away, we'd start, okay? Just
Thank you.
1 minute, please. She wanted to stop the other meeting because she wanted to go to the bathroom. So. Okay, Fanny, 5 seconds after the recording starts, you can go ahead. We have Frida, Jose, Dr. Katz, and Sally, okay?
Thank you. Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. First in the agenda is a motion to adopt the minutes of the Equal Employment Opportunity Committee meeting held on January 11, 2021. I would like to take a vote of all the committee members. First, Jose.
Yes.
Dr. Katz.
Yes.
Frida.
Yes.
Sally.
Yes.
Okay, the meeting are adopted. Next, we will have 2 reports, one from Matilde Roman, Chief Diversity and Inclusion Officer.
Good morning. So I just wanted to, if you can go to the slide where the graphs are. In January's meeting, we had covered workforce data, and I wanted to provide a side-by-side comparison about a workforce in New York City Health and Hospitals, the employee workforce versus the affiliate workforce, that you could see a side-by-side comparison based on the social identifiers such as race, ethnicity, and gender. As you see on the employee side, over 80% of the workforce are represented either as Black, African American, Hispanic, Latino, and Asian, and nearly 60% of the affiliate workforce also are from underrepresented minority groups. So it gives you a snapshot of the data. And if you go to the next slide, you shall see the same comparison both for employees and affiliate staff based on gender. And so it gives you at least some high-level overview of the global demographic data, both for our employees as well as our affiliate staff. I want to pause here, give you an opportunity to process and ask any questions that you may have.
Thank you.
Yes.
Thank you, Matilde. Sally, if it's okay, I would like to go in order so that everybody has a chance. Is that okay, Sally? Okay. Jose, do you have any question?
No, thank you so much.
Frida, any questions?
Just a question, a couple of questions, and thank you. This information is really important and useful. The affiliate workforce, is that all physicians?
The affiliate workforce represents both physicians, allied health chiefs, and administrative staff. So it's a composite. It's approximately 6,500
Okay,
total.
But it's
And-
strongly physicians.
strongly
It
physicians.
is strong. It is
I
strong.
mean, as a percentage, it's a good, I don't know what I would guess that it's like 2/3 physicians.
I would agree. I would agree with
1/3
that.
support.
Yes, I would agree with that.
And I guess more broadly, and maybe you'll get into this, and I apologize, this is my first time at the committee meeting, but do we have goals for either, on the employee workforce side or affiliate or metrics where we kind of look at our, the city population or patient population or other systems that we kind of benchmark to, or is that
That's a
something
great
that?
question. And I think that is our focal point, is always to find opportunities where we can continue diversifying our workforce and working. And I think later on in the presentation, we have Dr. Nicola Davis walk us through some of the work that's happening with Dr. Allen. You will see an effort that we are really looking at diversifying the affiliate workforce, especially physicians. And there's an ongoing effort by our Senior Vice President for Human Resources, Ms. Villanueva, with regard to really trying to look at opportunities where we can diversify our employee workforce as well when their opportunities arise.
Right. Okay. Thank you.
Thank you, Frida. I'm sorry, Dr. Katz, I can't skip you. I apologize. Dr. Katz, do you have any question?
Any order is good. No, I just feel very proud looking at our employee workforce and how representative they are of New York City.
Thank you, Dr. Katz. Sally?
Yes, I want to really build on Frida's question and looking specifically at the racial, ethnic, and gender breakdown of nurses. Hispanic Latino is 8%, Asian 37, African American 43. And I'm wondering, who is it that would take a deeper dive into the 8% Latinos to look at what factors contributed to it being such a small percentage relative to, if you just picked a figure, the representation of the population in New York. But I know there are all kinds of variables that would affect Latino participation. But is that a topic for focus and investigation?
Hi, Sally.
what
Oh, go ahead,
I
Mattel.
think that, yeah, Dr. Katz really emphasized the fact that I think as a healthcare system, we fare better than other healthcare institutions across the country. I think there is an overall shortage of both African American and Latinos going into medical schools. But, and Natalia can speak to the nursing programs in particular, but I think there is an overall national shortage that I think plays a part in the low numbers of physicians in both, African American, Black, and Latino representation. So Natalia, I cut you off, so I don't want to.
It's okay. So I think there's opportunity, Sally, to focus on recruitment of Hispanic nurses. I think when we look at data across the board, the percentage of Hispanic nurses are lower, but necessarily, just when you take a look necessarily here in New York City, I think we can do more. So we're partnering with the Hispanic Nurses Association and also with CUNY that has 14% of Hispanic nurses, and also creating pipelines for those who are Hispanic to become nurses. So I'm actually presenting at 3 p.m. today to talk about the deep dive that we've done in nursing.
Oh, terrific. I look forward to hearing that. Thank you.
You're welcome.
Thank you, Sally. I just, first of all, I want to thank you, Matilda, for this presentation, and I really like how you put the two graphics very nicely, aesthetically pleasing, but very informative. And as Dr. Katz said, it showcases how well the system is doing, comparing and trying to represent the communities that we serve, our patients. And I think this is something that we should be loud into. And I know that in other committees, we have been talking, and I would like to say Dr. Calamia has been a big proponent that some of the great work that we do in different areas, we should be able to disseminate it and communicate it with others so that they get and understand the work that we have done, but also share some of the practices and best practices. So I would say that maybe there is an opportunity here to share, particularly if it is, and I don't believe it's luck that we just happen to be in New York, and that's why we have a diversified workforce, but definitely it's a concerted effort by the leadership in emphasizing the value that diversity brings to our system and the support that it provides to our communities and our patients. So maybe that's something that I have to think about it, Matilda. Maybe there are some outlets in which this information can be communicated and disseminated. So that's one point that I would like to make. The second point is to follow up both on Frida and Sally's, and I know that in the past you have shown the breakdown of the different groups of the workforce, particularly the physicians, the executives, the nurses, and staff, other staff. So I hope that in the future we are able to see this decomposition and comparison with our workforce and our affiliate workforce, and perhaps share with us the programs that they are doing to diversify their ranks. As Natalia is saying, there is definitely outreach program, support for the pipeline that needs to be done. And I believe that all these affiliates will benefit for the increasing the diversity and because of the communities that they serve. So that's something that I just want to suggest, that maybe in future meetings we have the breakdown by groups, and also have information of what the affiliate are doing to increase diversity in the different groups.
Thank you, Fanny. We'll definitely take that into consideration and have it for you for the next meeting.
Thank you. I think you can continue the presentation. Thank you.
So I want to segue now to both Dr. Davis and Natalia Sianas on the Equity and Access Council report out.
Thank you so much. So today I will be presenting with Dr. Davis, Hart, and List. I am the co-chair of the Equity and Access Council, and we're very proud of the work that we've spent during the last 6 months or so, just setting the infrastructure here at New York City Health and Hospitals. The Equity and Access Council provides a strategic direction for the development of programs and initiatives really aimed at eliminating barriers, institutional and structural inequities, and improving the health and well-being of segregated and marginalized communities. Our Equity and Access Council here at New York City Health and Hospitals is comprised of 4 work groups. The first work group is evaluation program efficacy. So we will talk about the efficacy of our data today, and Dr. Hart will present that. Our second work group is around workforce, looking at initiatives to enhance talent diversity. Our third is workplace strategies to improve inclusive practice that I am leading for the system. And last but not least, the fourth work group is equity of care, really looking at strategies to eliminate racial and social inequities. Next slide, please. So our framework. So each project will be driven by equity work groups comprised of approximately 5 to 7 members and guided by 2 project leads to really drive goals and outcomes in each area of focus. The members will be tasked to develop a work plan, to look at pre and post metrics, and as we've talked about as a system, really also assessing milestones within each work group and establishing a timeline for each approved project by our steering committee. The council members will also offer equity work groups guidance and serve as an advisory and oversight capacity for the projects to really champion the work and be accountable for their project/success. Next slide, please. So I'm proud to report that we recently completed recruitment of our work group members. When we launched the Equity and Access Council last year, we sent out a global email and we got a lot of interest. And so we've invited all of those who are interested to come back and to hear more about our council. And we really believe that each work group will comprise of different stakeholders throughout the entire system to really drive projects. And I must say, the meeting that we had last week really entailed a variety of different stakeholders from facilities, nursing, physicians, social work. And so we really think the Equity and Access Council will be diverse in nature by background. Each work group will also establish work group profiles that will entail membership, roles, scope of work, and objectives. And I also want to report that we recently completed a facility survey throughout the entire system to ensure we really understand the current state of diversity, inclusion, and equity work that's happening throughout our system. And so we received good feedback, and we're using that feedback to really drive our projects. And now Dr. Davis will walk you through next steps for our work groups. Dr. Davis, are you on?
Sorry, got it. Thank you. So I'm going to be going through some of our drivers as well as some of our accomplishments. So in terms of some of our equity and access drivers, some of the things that we're really working towards that are going to really drive our work is building a robust data infrastructure that allows us to create disease-specific queries that will incorporate race, ethnicity, language, and other social identity categories so that we will be able to identify health inequities. We're also working to improve the accuracy and the reliability of the way that we collect race, ethnicity, language, sexual orientation, gender identity, and disability demographic values, which will also help in supporting our efforts at both improving healthcare delivery as well as healthcare outcomes. We will also be establishing inclusion groups that will allow staff to connect, collaborate, and support growth for physicians as well as other underrepresented groups. And we'll also be evaluating, and where appropriate, we'll be replacing race-based algorithms that are currently being used in medical care. Next slide, please. So now I'm going to go through some of our accomplishments and milestones. So under the Equity of Care work group, many of our members have been working with the Vaccine Communication Work Group, which has really been focused on how do we communicate effectively to improve vaccination rates. We've also accomplished removing some of the race-based algorithms in medical care. And I'm going to ask Dr. Hart, who's been really leading this work about race-based algorithms, to speak to the accomplishments that we've had there. Next slide, please.
Thank you so much, Nicola, and good morning, everyone. My name is Dr. Lewis Hart. I am a pediatric hospitalist at Kings County, as well as the Director of Equity, Quality, and Safety for the health system. It's a real privilege and a pleasure to be able to present this work to you. So this was an initiative that started out of the Office of Quality and Safety in close partnership and collaboration with the Equity and Access Council, titled Medically Racism. This work was really energized by a New England Journal of Medicine article that was published late last summer titled Hidden in Plain Sight, Reconsidering the Use of Race-Based Clinical Algorithms. The paper, the literature reports around 13 commonly used clinical algorithms that use race as an objective measure in biomedical algorithms or equations that provide different results or different calculations on the basis of subjective race, and thus provide different care based on that input. So in looking at this, we looked at national disparity statistics and realized that kidney disease, unfortunately in our country, the development of end-stage renal disease and the prevalence of chronic kidney disease differs across racial and often social lines. However, when looking at the commonly used equations that provide clinicians with an estimation of a patient's kidney function, which is known as estimated or eGFR, we noticed that, unfortunately, race is considered as an objective input in providing a different answer or a different response to a clinician when assessing a patient's kidney function. We knew that, unfortunately, in the United States of America, African Americans have a 3 times greater rate of developing end-stage kidney disease, and Hispanic or Latino Americans have a 1.5 times greater rate than white Americans in the development of end-stage renal disease. We looked at the current equations that we were utilizing, and we realized that while some did use objective measures like a patient's serum creatinine, which is a protein breakdown product, a patient's age, a patient's biological sex, as well as race. However, when calculating, they use Black and non-Black as the only 2 different races. We thought that this was incongruent with the diversity that exists in the world, especially the diversity that exists in our country, even more especially the diversity that exists in New York City, and didn't believe that anything that was as binary as Black versus non-Black could be providing the most equitable care for our patients. We weren't treating them personally. We were lumping them in social groups and thus, unfortunately, treating them based on that grouping. For Black Americans, the equations reported a 16 to 21% greater rate of kidney function based on studies that showed in their small underpowered, well, I shouldn't say underpowered, in their small studies that around the patients that the reporters identified as Black had higher levels of creatinine and higher levels of GFR or kidney function when measured. So unfortunately, when we looked at this, we saw that the unintended consequence of such an action would be to propagate a biological difference or biological cause for all Black bodies being different than all non-Black bodies, which again just seemed very incongruent with the work we do at health and hospitals and our understanding of personalized medicine and genomics. So when we looked at this, when clinicians are using EGFR to measure someone's kidney function and potentially dictate the care they're delivering, if we are artificially making at-risk or a sicker potential population, like unfortunately in our country, African Americans, we're artificially making their kidney function look healthier, there might be some benefits and there might be some risks. The benefits of this might be that they would be allowed to stay in studies. You know, there's a certain kidney function to be able to be a subject in a clinical trial. There might be certain medications they'd be allowed to continue if their kidney function was artificially healthier or looked healthier than if they were white. However, when we looked at the downsides, we realized that the way in which we stage kidney disease, this might, if by artificially making numbers look higher, we might delay the referral of African American patients to a specialist like a nephrologist. We might delay their referral to dialysis, and we might also delay their referral to kidney transplantation because, again, we are artificially, but using this equation, making their kidneys appear healthier than if they were white. So the work really started by convening a stakeholder group of our key nephrologists across the organization, known as the Nephrology Work Group, which is led by Dr. John Wagner out of Kings County. And we asked them about the inclusion of such a practice. This was in the late summer of last year, and about what their thoughts of including subjective race, which I think we all understand is a social construct that is not a consistent proxy for ancestral or genetic inheritance in their biomedical equations. And at first, they were very hesitant to get to kind of scrapping this practice or even reevaluating the practice, given what a hallmark study this was, led by Levy et al. Around the use of race as a important objective proxy in this biomedical equation. However, after much literature was published this past year around the idea and how this was inconsistent and how this only led to potential fallacious reasoning and really inequitable outcomes for patients, they did reconsider and they allowed me to present to their nephrology work group. The nephrologist on the work group said, "It's interesting that you say that because the patients that we see at health and hospitals unfortunately come to care much later. They come to care much sicker with more advanced kidney disease. And they gave the subjective sense that we already know where they're heading. So why are we artificially making their kidneys look healthier based on very small studies that are not representative of the diversity that we take care of here in New York City?" So really the process started with convening a few of the local leaders, then asking the whole nephrology work group to consider our proposition. And then really once the nephrology work group came to an understanding that they did not believe, as you can see in the key takeaway, they thought that the inclusion of race was fraught with bias and had lasting deleterious implications for Black patients. And for a multitude of social and scientific reasons, the work group felt strongly that the inclusion of subjective race, which is a social construct, as an objective biological proxy for either creatinine generation, how much creatinine a body makes, or creatinine clearance, how quickly kidneys clear creatinine, in a biomedical environment did not meet the scientific rigor required at health and hospitals of our diagnostic screening tools. So this was a very pioneering and landmark stance on this. There were very few institutions that were doing this at the time. I think we were the third or the fourth to do it at that time. Now there are around 15 large institutions, but out of the multitude of institutions that still exist in our country, we're still in the minority and still actually pioneering this work in terms of getting rid of this. From going from the nephrology work group, we then realized that we needed to socialize this process very heavily. And in one of the most democratic processes, I don't think I've been a part of any initiative that has been so well socialized around clinical councils, leading with the Internal Medicine Council, the ICU Council, the Women's Health Council, Quality and Safety Leadership, the Medical Professional Affairs, Equity and Access Council, Clinical Lab Council, our CMO Council, all going around making sure we were educating people on the use of this practice and ensuring that people understood the limitations and the shortcomings of using race and treating our patients differently based on their race in biomedical equations. So this was our first kind of our toes into the water in terms of looking at clinical race-based algorithms. And what we did is we ended up replacing the equation with a race-blind equation. We are aware that there are limitations of this equation, and there is new practice in the world of nephrology around a different equation that is much more costly. I should say a different test, testing for a different protein as a filtered product in the blood. It's much more expensive. It's not readily used. I think at Health and Hospitals, it was ordered less than 200 times in a 6-month period when looking back at, whereas EGFR was ordered close to 250,000 times in a 6-month period look back. So we know that that is the future of nephrology, but it is a little bit early in terms of cystatin P, and it is a little early in terms of the measurement of that. But we do realize that our current practice of using a race blind approach has the only limitations of, it wasn't validated in this group. But we felt very strongly that continuing to propagate the idea that there are biologically different causes in social groups on large scale at a universal level was inappropriate and caused more harm than good. So we will continue to look at, unfortunately, in healthcare, and this is well documented in the literature, as patients' kidney function deteriorates, clinicians oftentimes don't update the problem list and don't update and don't reclassify the severity of kidney disease. So it is hard to objectively measure how patients are being treated in the new process, but we will continue to educate our clinicians on this, educate them on the limitations of what EGFR does. It is not supposed to be a once and done test, as creatinine and GFR is not in steady state. It is fluctuating throughout the day and throughout the week. So this is something that is supposed to be used to trend over time. So we will be continuing to educate not only the nephrologists will continue with the internal medicine doctors, but us as an institution around the use of race in clinical algorithms. And this was our first really forte into the water, talking about race-based kidney function testing. So finally, Epic and our partners at Northwell and Cerner were able to remove race or the 2 racialized results and now just process 1 result, which would be the result that all non-Black bodies would get. And that's the single result that all patients will receive going forward in our health system. Any questions about this topic? I know I have another one that I'm going to be presenting on a second clinical algorithm. But just before we take, I wanted to see if anybody had a question on this.
Any questions? Thank you, Dr. Hart. Any questions? I just have a quick question about this. You mentioned other systems. So they are also have removed this this kind of approach when they are diagnosing patients?
Yes, I'm part of a collaborative that works across institutions, mostly at academic medical centers, but a few community hospitals as well. And our last count of all of the group's representation is that we had around 15 large health systems, from academic institutions to, again, a couple community health centers that have removed this practice. We know there are more out there, but we are still in the minority in doing this work.
Thank you.
Annie, I have some questions that, I mean, I can wait, Dr. Hart, until after you're done with the other one, because they're probably more broad in the work you're doing, which frankly I find amazing. Like, I think this is really, I don't know a lot about it, but this is clearly groundbreaking. And one of the questions is, how do we get that beyond the 15 other health systems and sort of, get the work that you're doing here more into the broader dialogue and practice. And the other is, and I think you addressed this, and I might have missed it, that are we able to track how this shift in removing racial inputs into the algorithm, how does that affect the treatment and the outcomes and better equity in care? Is that something that we're able to do, or do you have things put in place to do that?
Yeah, I mean, it's a great question that you asked there. I think that the ultimate process or even outcome measure of not utilizing race-based EGFR will be the utilization of the newer equations that use a different biomarker for kidney filtration, which have been well validated across racial groups as a universal constant. So I think, given the fact that we only used that test, I think it was 118 times in a 6-month period look back, compared to the 248,000 times we had used EGFR, which just comes on the very commonly ordered basic metabolic panel that we all order on our patients. So I think, obviously, that's the trend that we're getting to. It's just a very cost prohibitively expensive test right now. So if we were to do it on scale, it would be, again, cost prohibitive. But I think that is the ultimate, because this is a workaround, but this is not probably the most ultimate, final answer in terms of how best to measure our patient's kidney function. It will be the biomarkers that don't require a race-based stratification or a race-based coefficient. In terms of measuring differential care that they will receive now that they're kidney function is no longer being measured on a racialized basis. It, again, is difficult, as the literature supports, just because clinicians don't do, unfortunately, the best job of documenting the care in their electronic medical records in terms of changing the actual disease severity in the problem list. So it's something I'm working with the nephrologist on in the nephrology work group on what are the best ways to measure differences, but this keeps coming up in conversation as a limitation to the practice. These are downstream measures. These will not affect the development of kidney disease. It might cause earlier referral, which might mitigate, but again, like we know, so much of our inequities in healthcare happen before the four walls of the hospital. We just wanted to ensure that we weren't perpetuating them or continuing to allow unfortunate eugenic practice of treating biological bodies different on the basis of race. But it is a very good question and something we're continuing to look into. But this is an issue that many health systems, every health system that I've talked to that's done this, are looking into. We are looking at, since we don't do transplantation here, we are looking to at dialysis numbers and looking at racial demographics and to see if that changes at all. But it's a very good question.
Lou, I think you're underselling the value of the education that you're doing on getting people to refer appropriately when someone might need a transplant or when someone might need an intensification of their medication, right? Because part of the problem, which exists more on the primary care side before they get to the nephrologist, is using the flawed race-based measures. A primary care doctor is going to say, oh, this person doesn't need a referral yet for transplant, or they don't need a referral to the nephrologist because their estimated renal function using the flawed measure looks okay. I'll wait a little longer. While, educating people on why not to use that, I think will affect the ultimate referral of people for transplantation and for intensification of use of ACE inhibitors and other. Dialysis is, as you know, more a question of the whole field is not sure when is the best time to start dialysis with, early dialysis camps and late dialysis camps. But transplants obviously tremendously improve people's quality of life. And the use of ACE inhibitors and other medications really can slow the progression of some forms of renal disease. So I see that as two of the big victories that your work has.
Thank you so much.
I want to echo what Mitch said, and Lou, Dr. Hart, I'm most impressed with the work, also in terms of how you're trying to change some norms that are in place that, whether they were intended or unintended, are difficult to change nonetheless, and it's highly technical work. So congratulations, and I'm glad that you're playing that leadership role not only for H&H, but across the nation. Thank you.
Thank you, sir.
Thank you, Dr. Hart. So you're going to cover the next one?
Yes, please. So this was our next clinical target, and this is around the counseling that obstetricians give their pregnant patients around whether to pursue a vaginal birth or a C-section for the second delivery. So often, and just for the non-clinicians in the room, when a woman is pregnant for the second time after having an earlier C-section delivery, whether that was emergent or whether that was planned, they might be at an increased risk for a dangerous delivery in terms of, since there is an incision that has now been repaired on the uterus from the primary delivery, there's an increased risk for things like uterine rupture, which can be very deleterious and carry a lot of morbidity and mortality for the woman and for the birthing baby. So there are clinical tools that obstetricians have developed over time and calculators to help potentially guide an obstetrician and a patient's decision on whether to pursue a vaginal birth after an earlier C-section, also known as a TOLAC or a trial of labor after C-section, or whether to proceed right to C-section for what is thought to be a potentially safer means of delivery in a patient who might be higher risk for a bad outcome during that labor. So when looking at these clinical equations, these three major clinical equations came to the surface, and this was also reported in the New England Journal of article that described the 13 clinical algorithms. So these were formulated in the late 2000s, and they include risk factors such as a mother's BMI, such as a mother's age, her clinical history of how many successful or difficult the labors she had prior but also includes Black race or Hispanic ethnicity as also clinical inputs that would then change the likelihood or decrease the likelihood or change the likelihood of a woman being successful in her vaginal birth after C-section. So for Black women, it actually decreases the estimated success of having a vaginal birth by 67%, and for Hispanic women, decreases the likelihood by 68%. We asked where this actually came from, and this was in retrospective analysis of data, looking at which women had successful vaginal births after C-section versus which didn't, and thus they noticed differences across racial ethnic lines and estimate or hypothesize that this might be valuable to include in screening algorithms because maybe history will repeat itself and populations will continue to have the same outcomes. So the unintended consequence of this is that it actually normalizes pathology, as opposed to saying maybe women who come from different socioeconomic backgrounds and have different access to prenatal care, different access to clean water, healthy foods, clean air, have different outcomes. As opposed to saying that's pathology, we should potentially intervene earlier on. We normalize that pathology and we say it's normal for Black and brown women to have different outcomes around delivery. So let's just risk adjust that away and let's offer them different levels of care downstream at the tail end, as opposed to going upstream. And again, I think the unintended consequence of this again is to perpetuate that Black and Hispanic women's bodies or the reproductive organs are fundamentally different than a normal body or a non-Black or Hispanic body, and thus reinforces the false idea that race is itself the biological proxy, not things such as racism or classism, the things that we've all allowed as a society to flourish, and the things that are most likely driving these differential outcomes that exist across racial ethnic groups. We know that Black women in our country have, I think it was recently published, anywhere from 3 to 6 times greater risk of dying during delivery than white Americans. So when looking at this, we realize that not only can bias determine the levels of care that providers give, but that the actual equations, the actual structures of our healthcare system are also potentially adding to the deleterious outcomes and are potentially perpetuating the differential care that we provide our patients. Again, by normalizing pathology, we now potentially would counsel our patients differently on the basis of their race, regardless of their socioeconomic class, regardless of other potential more important socio-demographic factors, but just looking at someone's race as a proxy that's supposed to represent everyone and their body of work and their lived experience. We know very commonly that in statistical analysis we can risk adjust away things, but in life you can't risk adjust away your lived experience of discrimination, of inequities of care. So again, for very similar reasons, we went through the same kind of thought experiment and practice where we convened leaders on the Women's Health Council, and we brought to them this equation as something that was very important and something that needed to have awareness raised on, and to ensure that we weren't continuing to use such a practice in our health system, given the demographic of the patients that we take care of, being a majority of Black and brown women that we actually deliver their babies here in New York City. So we were very proud when we partnered with the chairs of the Women's Health Council that they said we actually had this thought experiment in late 2000s, I should say early 2010s, around whether we should be using such a practice. And they thought that it was actually flawed in its intent and in inherently. So they actually they had decided to not include this practice as something either in the EMR when we did actually integrate Epic across the network, and actually never taught it within any of their grand rounds. They never taught it to their trainees. This is something they were very proud of, the fact that they never wanted to use here at health and hospitals. So for the same reasons, they felt that this, the inclusion of race in this biomedical equation, acting as a biological proxy and not the subjective social construct that it is, did not meet the scientific rigor at health and hospitals. So we were actually very proud, and so was the Women's Health Council, of continuing to reinforce and really emphasize the deferral of such a use of such a unfortunately race-based or racist practice. And so we wanted to take a deeper look into the numbers to see, since we don't use this practice, how do we actually compare to the state and to the rest of the nation? Interestingly enough, and there could be some potential difference in reasons, and this is in the last line under the plans for further action. This is evidenced by our cesarean section rate below the New York State average. We, on average, about 19% of our pregnant mothers deliver via cesarean section, compared to the state's average of around 23%. We also were like, okay, but potentially there are different financial incentives around why we would not want to do a cesarean section compared to a different system. So let's actually look at the rate of how many actually have successful vaginal births after C-section, which is a truer marker of the counseling that they received prior to delivery. And we actually saw that our VBAC rates were actually greater than the New York State average. by a large amount, by almost 50%. We had a rate of around 19% versus the state's average of 13.3%. So this really reinvigorated us and made us very proud around our continued use, and really recommitted us to using the most empirically relevant data, such as those objective measures. We know that unfortunately race in our country does matter and does oftentimes can predict things, though inconsistently. So it's not like we were throwing the baby out with the bathwater and are not going to be considerate of this, but we want to tailor and personalize the care that we deliver to our patients, and ensuring that we are taking those unique social histories, that we are understanding the social impediments of health that our patients and all patients experience at various levels, and really starting to tailor the care based on those, not on a biological, not on some kind of universal imperative of race, and really just kind of using a blanketed, binary approach. So this was another way that we were able to really double down on this practice, continuing to educate our providers, and trying to work with the American College of Obstetricians and Gynecologists around finding new clinical equations that would better predict a woman's ability to be successful in having a vaginal birth, which can oftentimes be a safer way of delivering a baby.
Okay, thank you, Dr. Hart. I don't know, Dr. If we have other part of the presentation?
Yes, we do have a few more slides.
Okay.
So I just wanted to thank Dr. Hart for that. This is really tremendous work that we've been able to collaborate and work with. And we've just had such great support from across the system, from our clinical laboratories in terms of eliminating race-based GFR, as well as all of the clinical council. So it's really been a great collaborative effort across the system. So thank you so much, Dr. Hart. So we're just gonna have a couple more slides that just speak to the continued work in some of our other pillars. So in terms of workforce diversity, we've had some accomplishments there as well. We had a really successful screening of a movie called Black Men in White Coats, which is a documentary that focused on the devastating and disproportionately low rates of Black male physicians in the US. And in this screening, we had about 1,000 community members sign up for the screening, as well as we had a panel discussion, which had about 200 community members involved in the panel discussion. And it was a really robust, rich discussion led by 3 of our Black physicians, including Dr. Hart, Black male physicians. So that was fantastic. We also have our Physician Diversity Initiative, which is really aimed at improving the diversity of our physician workforce. And these efforts really involve a strategic alliance with our affiliate organizations, which we've been encouraging through our contracting process to really build a sustainable plan for recruitment and retention of a provider workforce that will better reflect the patient population at our hospitals. Next slide, please. In terms of our diversity by numbers, we know that this was a survey that was done by Modern Healthcare, which showed that for health and hospitals, we had about 46% of our senior management that were ethnic or racial minority groups, which was higher than most of the other hospital systems, and something really for us to be very proud of. Next slide, please. But we know that there is still work to do. Even though we might be better than many of our systems, we know that there's still room for improvement. And as we can see here, when we look at all leadership, when you go from first line management up to higher executive levels, there are lower rates of African Americans, Asians, as well as Hispanics. So, but specifically more lower rates of African Americans. So there's work to do there for improvement. Next slide, please. When we look at gender and all leadership, we do very well, and we do have women represented at all levels of our leadership. Next slide, please. So just a few remaining accomplishments. So for our inclusion work group, we have started to establish some inclusion work groups. We've started with a Black female physician work group, which will have its first meeting this month. And in our evaluation work group, we have been working on convening a multidisciplinary data team to really streamline how we collect the race, ethnicity, and language data, as well as the SOGI data, how it's collected across the system, and how it will be analyzed and used across the system. And so that is really critical work that is ongoing as well. Next slide, please. So our next steps are really convening the equity work groups. And as Natalia said, we had a really great meeting bringing together many members across the system last week who all want to participate in our various work groups. We will be working on developing our work plans with specific timelines, as well as really doing a lot of thinking about what each metric will be for each work group and thinking about those success metrics. And I believe that's it. Any questions?
Thank you, Dr. Davis, for a wonderful presentation. Again, thank you, Dr. Hart, and of course, Matilde, for wonderful presentation. I would like to go over the committee members if they have any question about either the part that Dr. Hart presented, the last part, or Dr. Davis. Jose, any questions?
No, just to commend the whole team, Dr. Davis, Dr. Cineas, Dr. Hart, Dr. List, and so on, for all the work on, and Matilde, all for putting this together. I mean, you've done a lot in a very short period of time, where there's a lot of things going on in the background, and it's just very impressive. And I know that you'll get a lot of interest in this. And I just want you to know that you have full support from the board on this. We often talk about issues like this, and we're very, very glad that we have a great team looking at them. So I just wanted to say that. Thank you.
Thank you, Jose. Dr. Katz?
No further questions. Thank you.
Thank you, Dr. Katz. Frida?
I just want to echo what Jose said. I think this work is really important, and I'm really very impressed at all that you guys have done already, and the focus areas are really on point and broad, and so thank you. And I'd love, and I don't have, in the interest of time, lots of questions, but I'm sure as the work develops, we'll be hearing more. And so I look forward to that very much. Thank you.
Thank you, Frida. Sally?
Just, I think I'm especially awed by the work done on the kidney disease and the C-section study, because they impact our patients so much. So just kudos on that, as well as the entire presentation. Thank you.
Thank you, Sally. Again, I would like to echo what all the colleagues in the committee has mentioned. Great job. We could not have asked for a better team to really be advocating, looking reflectively of our actions, our processes, and how we can always challenge ourselves to really identify how we are able to look at each our patient as an individual and respect them and really bring all our expertise. So I just want to thank all of you. Of course, I would like to thank Dr. Katz for your leadership. I know it takes everybody, because you have so many things that you have to worry about it. And most impressive is that even during this year in which we all and the whole nation and the world has been concerned about COVID and being affected by COVID, you have kept the work of looking reflectively our practices and ensuring that we do right for our communities and our patients. So I just want to thank everybody. Again, Matilde, Dr. Cineas, Dr. Davis, Dr. Hart, and Dr. Katz. Thank you so much. And I just have one question. I'm sorry, I always have a question. If you go back to that chart that shows both our demographics, I always like these charts because it shows kind of a little bit of an interesting phenomenon. No, go to those charts in which it shows the different level from the executive. We see the progression, but it seems that the senior management is an area that maybe close attention may be paid, because we see how from senior management then go to the executive. So I don't know what will explain that kind of difference, but you see how the numbers kind of change from senior to executive. Maybe that will require a little bit of a closer look what are some of the things that we want. I know that when I was doing research, and this was in the early 90s, we did find that there is a kind of alignment between the executive level and the entry level personnel, but the middle level had a totally different view of the world. So I don't know if there is something at play here similarly, but I think, the way that we evaluate, the way that we kind of recruit, there may be certain things that will be interesting to look at. That's just a comment. But again, I want to thank all the members of the council for the great work. So if there is no other old business that anybody wanted to discuss? Any new business? Well, with that, again, I apologize again for starting so delayed the meeting. We really appreciate your patience, and again, that you were able to share with us the amazing work that you are doing. So without further, if there are no further discussion, this meeting is adjourned. Thank you so